Thank you, Dr. Guha, for joining us. So, can you just give us a brief summary, first of all, of your two presentations, yesterday and today, talking about ECT, schizophrenia, and clozapine?
Right. Thank you, Caroline. It's been a pleasure to talk about two of the most underutilized treatments in psychiatry, but the two of the treatments that actually has been a boon to psychiatry for over 5 decades. We all know ECT has been there for over 7 decades, and clozapine has been there for 5 decades, and I do believe that they are most regulated because of certain issues around these two treatments, but I believe that we are underutilizing two valid treatments in psychiatry because of our inadequacy in our thought process, or maybe we are not supported by the various algorithms that come out from the regulatory bodies like American Psychiatric Association or NICE guidelines, or even our own college guidelines. So I believe that most of the literature that has come out from the East on similar treatment-resistant schizophrenia and the usage of ECT and clozapine has relatively been ignored when the consensus guidelines have been drawn up. And I would like to advocate that when we do such a review, we take in a lot of meta-analysis from a lot of these studies and even case reports. It may not be an RCT, which is difficult to be conducted. It should be whatever evidence we get from wherever, we should be able to link up, and obviously the value of each depends on the depth and the breadth of their research protocol. But I believe the narrative approach in what works in psychiatry is more important than randomized controlled trials, which often in psychiatry, especially in the field of ECT, is very difficult to conduct.
Right. And you gave a very compelling case study of a patient, 39 years of age, who's had schizophrenia, 39 years, was thought to be resistant to treatment. Can you just give a brief summary of that case and then the outcome as well?
The case that I described today was basically a person who was described as treatment-resistant or neuroleptic resistant schizophrenia for over 10 years and has multiple admissions because of adherence issues, and the person was on a long-acting injection, risperidone Consta, was not responding, but nobody thought about a second opinion or reviewing the dose of medications. The difficulty in this case was the remote setting this patient came from to the suburban hospital, and the fact that the case management fell over because he was not being found to be given that injection. So what was happening, a struggle between the case manager and the patient, whose insight was so poor to a degree that he was trying to run away to the bush to avoid his medications, and that led to his admission in early February 2009 under my care. And having had already doing a trial on possibly giving ECT and clozapine a bit more liberally than the college guidelines or other guidelines would suggest, I thought, why not we try and get an understanding of the person's neuroleptic resistance status, and if that is true, why not we start talking about ECT trying to be the icebreaker of causing some insight developing, and there are some robust studies on that, and then followed by exploring whether clozapine would be the best way to go. That was part of the 4 patients trial that I was talking about there. In this case, obviously, the person had some forensic problems and did have a forensic review by a psychiatrist who actually supported my plan, and he had definitely some range of first-rank symptoms and capgras delusions, and he was deemed quite dangerous to the life of his parents. So there was definitely a discussion around how we could maximize his treatment outcomes by recruiting ECT and possibly, if so required, clozapine. In this case, of course, we gave him a couple of ECTs, and we saw that from being in a high dependency unit, very paranoid, very disturbed, very dysregulated, this person actually was trialed outside into the open ward. That was the first sign that he was manageable. The insight was coming, though he completely denied his illness. But having said that, for 3 or 4 ECTs, we could actually sit him down and talk about clozapine, gave him some info that he sort of registered, came back to me after 2 days and sort of reluctantly agreed. Basically said he would prefer oral tablet than injection, which all of us would. And I took that as a yes, and then tried clozapine, and then that showed a lot of effect actually, and as I said today, a reasonably short period of time we could actually have symptom resolution. Though his discharge took some time because of the remoteness of where he came from, but and the problem was that we had some hiccups of another consultant deciding to stop clozapine because of some cardiac rhythm disturbances, which was a minor hiccup, but that wasn't explored. And this brings me to the next dimension of are we psychiatrists resisting to treat people because of our own inadequacies in training, understanding, or maybe inflexibility to try and put the consumer's needs more than our needs for our credentialing needs, that what we can do, what we cannot do. So even when I took a second opinion on this case, my colleagues didn't support me going down this track, which is surprising given that this person more or less was quite severely treatment resistant, and his outcome was looking at a very long stay, medium secure place where his life would be regulated by the four walls of our unit, compared to after 2.5 months he was discharged back into the community. And the most I lost track of him because I moved on to another service, and obviously don't keep track of patients what happened. But when I was trying to think about some interesting things I've done in the last 1 year, and opened up his case records from whichever site I was in, and found that he was so successfully rehabilitated back to his remote town, connected back with his parents, and he was trying to build a house for a mate of his, and on oral clozapine. Even the risperidone constant injection that I discharged him with was dropped, and even the case manager, by the sound of it, was thinking of dropping his involuntary treatment order. And if that is not a good recovery, what is? And the case manager, if I quote the case manager saying, this is the best this man has been for a long time, that this person has been known to the service. So I thought that was definitely a turning. And it's not, if it was one case, I could call that as a bit of miracle or God's hand, whatever you call it. But the 4 cases which were significant amount of response by ECT augmentation to clozapine, ECT augmentation of antipsychotics, and even in one case, actually I was switching antipsychotics, I'm reducing the clozapine dose to shift over to ziprasidone, and ECT was used in between because obviously the person was getting more and more unwell, but there are reasons why we couldn't use large dose of clozapine on that lady because she had a lot of metabolic syndrome and sleep and weight problems. So basically we used ECT, she became better, her depression went off, and the depression was treatment resistant in that case, and she was obviously chronically having schizoaffective disorder. So she had chronic schizophrenic symptoms, she had treatment resistant depression because we tried 3 different classes of antidepressants, couldn't get a response. ECT quickly changed that. Even at the end of it, before she became advocate for ECT herself, and apparently is now sharing the teaching with another consultant or medical students on ECT and medications and other stuff. So she actually said that after ECT was given, her antipsychotic response was much better. She heard voices for less time of the time. She was not paranoid. She was not scared to go outside. So she was cognitively also getting better after ECT. And we only used 5 ECTs in that case. And she's right now on a very low dose of clozapine, 125 milligram, with a bit of Abilify augmentation. And that's another range. Do we mix antipsychotics in lower doses so that we don't maximize on the side effects, but we get the benefit of the positive effects, knowing fully well that antipsychotics sometimes works on different pathways in the brain, so maximize that.
So lastly, why do you think there is this resistance towards using ECT here in Australia as opposed to the other countries that you spoke about, say in India, in other developing and developed countries? Why the hesitance?
It's because I think as a result of institutionalization also comes to my mind. People were generally thought about they didn't recover with the mainstream therapy, they could go into a long rehab ward and stay there for a number of years. So there has to be a dimension shift in people's thinking that now it is a community-based treatments. How do we get people to go back to the community? I think that hasn't got setting. In rural settings, I believe that there is a reluctance of using ECT because maybe there are the availability of ECT is in question, then the competency of people who use ECT and their knowledge on ECT obviously becomes a bit. Even in the services where I was so passionate about ECT, most of my colleagues actually, and my colleagues were not against ECT, but they were not proactive in prescribing ECT outside the college guidelines, when the college guidelines are pretty restrictive about where you can use. So it took me Herculean effort and a lot of educational sessions, even in the small institution I worked in, to get this done. When I shifted to a metropolitan hospital, which obviously had a huge department and I was a director of ECT in a Brisbane-based hospital, it still was a struggle for me to understand why people were there locked into a locked ward for 50 days, 60 days, and ECT was not even considered. And the response I got was that ECT in schizophrenia possibly doesn't work. So that gave me a lot of thinking time to research, and I found a lot of meta-analysis, pilot projects, case studies, even Australian case study. I did mention about Dr. Harry Hustig in South Australia doing the study. So there are a variety of good work being done, but it's done in small pockets, underreported, and if it is reported also, nobody is using the best tool that I know in psychiatry, Google, to find that out and explore that. And the hopelessness that I sometimes feel is just because people are stuck to a situation with a difficult to treat patient, they're not willing to experiment outside the box. And that unwillingness is not a treatment resistance, it's the resistance from the therapist to treat.
Okay.